Laser enucleation of the prostate is the state-of-the-art for definitive management of BPH. The procedure can be challenging to learn with initially longer operative times. There is growing hospital attention for volume overload with unrelated procedures secondary to excessive intra-op fluid absorption in CHF. Most of these cases involve excessive intraperitoneal and intravascular absorption, however. Fluid thresholds have been established across the board, irrespective of the type of endoscopic case. At our institution, the upper threshold is 2,500 cc's, at which time surgeon consideration should be to look for case termination. The risk with LEP for excessive fluid absorption is primarily related to capsular perforation, with extraperitoneal leak rather than intravascular or intraperitoneal absorption. The problem is exacerbated by prolonged OR time, especially when perforation occurs early in the procedure. The already challenging learning curve is now further complicated by heightened scrutiny of fluid absorption.
En bloc LEP is a significant innovation of established whole LEP technique, including gilling and ligament technique. It establishes early identification of the capsule at the apex, greatly facilitating the entire dissection. Technique as described includes early posterior dissection where capsular perforation is the greatest risk. Modified en bloc LEP is resequenced en bloc LEP. The posterior space enucleation step is deferred until later in the case so as to avoid the potential of prolonged fluid extravasation absorption time. It includes priorities of maintaining the lowest infusion pressure possible at 30 millimeters of mercury at the pump level and further control at the scope level to reduce flow to minimally necessary for adequate visualization. Modified en bloc LEP can utilize furosemide diuresis to offset fluid absorption calculation, reduce potential intravascular overload, and provide diuresis post-op, facilitating more dilute urine. Reordered steps are primarily to delay the posterior space dissection until the end. The priority is to maintain the lowest fluid pressure possible. Equipment includes the Convergent Laser ProTouch 1470 nanometer diode laser, Richard Wolf 26 French laser resectoscope. The settings are 40 and 65 watts for dissection. 40 watts is utilized whenever we are near the apex and also in the space between the capsule and adenoma. 65 watts is utilized for incising adenoma at 5 and 7 o'clock and also in the proximal half of the prostatic urethra, dissecting adenoma off the capsule and off bladder neck. Steps involved in modified en bloc LEP include the following. 1. Full inspection, identification of landmarks, and 5 o'clock partial depth incision. 2. Left apical incision to the capsule at 5 o'clock with mucosal hockey stick incision. 3. Roll-up of posterior apex progressing to lateral and anterolateral spaces. 4. Anterior space creation tunneling to bladder neck. 5. Anterior bladder neck mucosal perforation widening medially and laterally. 6. Anterolateral separation down to around 3 o'clock. 7. No further enucleation on the left side or posteriorly. We move to the right side and repeat steps 1 through 6. 8. Anterior strip division and completion of anterior space. 9. Sequential right and left or vice versa posterior enucleation. 10. Median lobe enucleation. Step 1. Inspection and 5 o'clock incision. We inspect for landmarks including inspection of the bladder, identification of UOs and viru. Then we make the 5 o'clock partial depth incision from bladder neck to viru at 65 watts. The purpose of the 5 and 7 o'clock partial depth incision is to facilitate irrigant flow in order to obtain optimal visualization. Secondly, we would like to mark the respective luminal locations at 5 and 7 o'clock for division of that intervening adenoma in the latter part of the case once the posterior space has been established. These incisions are more efficient because we make no attempt to reach the capsule and therefore avoid any risk of perforation at the beginning of the case. Here we are making that 5 o'clock incision after inspection. We want to make a partial depth incision to increase irrigant flow, but we make no attempt to reach the capsule so as to avoid any chance of perforation of the capsule early in the case. Step 2 is 5 o'clock incision in line with the previously made partial depth incision. We're going to complete that 5 o'clock incision down to the capsule at the proximal viriu and then flare it out on the prostate adenoma through the mucosal veil. We will then expand that posterior apical defect off of the capsule, moving retrograde using blunt dissection and some sharp dissection as well. We move up counterclockwise, rolling up that apex. We make no attempt to precisely incise between the junction of the adenoma and sphincter, but rather elevate that BPH adenoma off of the sphincter with blunt dissection. The distal aspect of that 5 o'clock incision is continued down to the capsule at 40 watts at the proximal viriu and then flared upward on the BPH adenoma mucosa, incising through the mucosal veil. We then elevate the BPH adenoma off of the capsule and elevate it away from the sphincter, expanding that space between capsule and adenoma, working both medially and then counterclockwise up toward the lateral aspect of the adenoma, continuing to work retrograde somewhat to roll up the apex, and then working further counterclockwise up to the lateral and anterolateral aspects. In step 3, we expand the posterior space, working retrograde and then upward counterclockwise, laterally and anterolaterally. This is done at 40 watts. One should also remain mindful about the potential for missed apical attachment and should pull back periodically to check and confirm that the distal prostate adenoma has been freed before moving further up in a counterclockwise fashion. Step 4. Next, we develop that anterior space. We confirm that the distal adenoma has been mobilized and freed before moving anteriorly. We need to pay attention to the angle of approach as we near the bladder neck, elevating the camera so that the scope is parallel with the floor. We widen the space from 12 o'clock to lateral, and we can utilize either 40 or 65 watts. Here we are working counterclockwise, rolling up to establish that anterior space, utilizing a combination of blunt and sharp dissection. We have been at 40 watts, but we can go up to 65 watts at this point. We're mindful that we have freed all of the distal prostate apex. We want to go beyond the midline, go beyond 12 o'clock before working more proximally toward the bladder neck. As stated earlier, we want to be mindful of the axis of the scope so as to not obliquely go across the bladder neck. We want to angle that scope a little bit downward as we reach the bladder neck. Step 5, we perforate the interbladder neck. We recognize this grayish translucent layer and go through it and then widen it both medially and laterally. In step 6, anterolateral enucleation, we carry that anterior bladder neck defect laterally down to 3 o'clock. Step 7, right lateral lobe enucleation, repeating steps 1 through 6, beginning with 7 o'clock incision. In step 8, we divide the anterior mucosal strip utilizing 40 watts. Anterior mucosal strip lies between the bilateral anterior defects. We are dividing the anterior mucosal strip from left toward the midline. We want to divide this at 40 watts. Here we are on the right side, going from lateral to medial, incising near the adenoma rather than near the sphincter. And one can see the anterior commissure coming up shortly just below the laser, right there. We want to complete this incision from right to left and left to right to completely free that anterior mucosal strip. Subsequently, we want to divide all of the anterior attachments to release that anterior prostate. Step 9 is posterior space enucleation. We have deferred this step because of the risk of capsular perforation and perform this toward the end of the procedure. We start by working laterally to medially, staying on the capsule. Next, we will complete either the 5 or 7 o'clock incision and work from medial to lateral, and then work retrograde toward the bladder neck. Here we are working in the right lateral space, dividing the attachments between the capsule and adenoma, working up on the reflection of the bladder neck. We're now working retrograde, rolling up the apical adenoma, and again going underneath that adenoma and going up the face of the bladder neck. Next, we move to the medial aspect of this right lateral lobe adenoma. In this case, we're going to complete that 7 o'clock incision, working from the posterior space and incising that adenoma against the capsule. This will complete the 7 o'clock incision and allow us to work from medial to lateral, undermining the adenoma from that 7 o'clock incision. Here we are completing that 7 o'clock incision while undermining the medial aspect of that right lateral lobe, working up the face or reflection of the bladder neck. A great deal of this dissection of the lateral lobe is done side to side. Direct retrograde enucleation is also performed. This is much easier to accomplish when the attachment underlying the adenoma has been narrowed bilaterally. Once the right lateral lobe has been completed and released, we will move to the left lateral lobe and perform the same dissection. We work from lateral to medial and then retrograde, and then complete the 5 o'clock incision, working medial to lateral until we release that BPH adenoma. The lateral lobes are attached, so once the second lateral lobe has been enucleated, the attached bilateral adenoma should go into the bladder. Step 10 is median lobe enucleation. The median lobe will be narrowed compared to other techniques because of the focus in this technique on the lateral lobes. It is relatively straightforward to take this down to the capsule, dividing into proximal viriu and rolling it up toward the bladder neck using a combination of blunt and sharp dissection. We can use either 40 or 65 watts.
In conclusion, modified en bloc LEP provides the most efficient technique for LEP or HOLEP. Attention to fluid deficit by hospital administration has increased, and this priority can further distract from the appropriate focus on the procedure. Safety is certainly a concern, with the potential of extraperitoneal absorption causing increased intra-abdominal pressure, which can cause substantial pain and potentially cause pulmonary compromise from limitation of diaphragmatic excursion. CHF from volume overload remains a possibility as well. Unnecessary exposure to this risk can be greatly diminished with these modifications while enhancing the technique overall. Surgeon attention to this case with a more structured plan can enhance and facilitate learning and completing this procedure consistently and safely. Thank you.